All right. Now, when we talk about sinus rhythms, we're talking about like normal rhythms, or I should say, rhythms that go through the normal conduction. Okay. So we have a normal sinus rhythm, and you all know that has a heart rate between 60 and 100. It's going to be regular. All of these are going to be regular, right? They're going to have regular R to Rs. The P waves are all going to be smooth, rounded, upright, and one before each QRS. The PR interval is going to be normal, so 0.12 to 0.2 in normal sinus rhythm, sinus Brady, and sinus tach. In first degree block, the PR interval is going to be greater than 0.2, okay? Now, the reason I teach first degree block with the sinus rhythms is because it's not really a true block. The conductions just slow down through the AV node. The AV node is the gatekeeper. And the reason I teach it here, it's just easier because it actually is a sinus rhythm. It goes through the same channels, the same electricity gets produced, okay? All right, now the QRS in all these rhythms is going to be narrow. Narrow is normal. So if you're doing a quick look, you want to see narrow QRSs, because if they're wide, it means it's a ventricular rhythm. Okay, so these are all normal. Now, you probably learned by now that less than 0.12 seconds means it's narrow. That doesn't always mean you have to take out your index card and measure it. You can see here that all these QRSs are narrow, and that's what we want to see. Okay, the ST segment needs to be isoelectric. I wouldn't even sweat this, okay? When we get to coronary artery disease, I'll show you some elevated ST segments and some lower ST segments, but the rhythms I am teaching you are all very basic rhythms, okay? Simple, simple, simple. So we're not going to worry about that just yet, okay? So in all these rhythms, when your patient presents with one of these rhythms, we're always going to assess. I'm not going to just say, oh, he's in normal sinus rhythm, he's fine. I'm not. I'm going to check for a pulse. I'm going to do like a neurological assessment. I'm going to make sure he has good, blood pressure. And if the patient is good, is doing well, then we continue to monitor. If any of these rhythms have no pulse, that means they're in pulseless electrical activity, and I'm going to talk about that later. But that's just one of the reasons we always assess, because just because your patient has a rhythm does not mean he's perfusing, okay? So having, being on a telemonitor or a bedside monitor does not mean the nurse doesn't have to assess. We do have to assess, okay? So normal sinus rhythm is our favorite. So that's normal. We don't need to worry about it after we assess. Sinus Brady is a heart rate less than 60, but all the same characteristics. Now, your brain receives 25% of your cardiac output. So if your rhythm is too fast or too slow, your brain may not be perfusing. So you want to make sure the patient's not getting confused and drowsy, okay? So you always check the LOC with the vitals, all right? And then if your patient is stable, you're going to investigate, right? So if you have somebody with a heart rate of 40, you're not going to just say, okay, the blood pressure is great, I'm not going to look into this any further. You need to investigate, okay? Athletes can have very low heart rates, people on beta blockers, you know all these things. You don't need to memorize that, okay? Neurogenic shock, we're going to be talking about shock 2 weeks from now, and it's the only shock that does present with bradycardia. Now, okay, we have a patient that has sinus bradycardia. Vital signs stable, LOC is good, I'm going to investigate. Why is my patient bradycardic? And if your patient's doing fine, it's okay. You don't need to do anything further. However, if your patient is now unstable, we need to treat it. And the treatment for unstable sinus bradycardia is atropine, because it's going to speed up the heart rate. Okay, you don't really need to know the doses, but we're going to give atropine. Now, After they give atropine, they may give like another pressor or something like that. If needed, they would put in a pacemaker, but usually medication works with sinus bradycardia, okay? Then with sinus tachycardia, that's a heart rate greater than 100, we're going to do the same thing, check the LOC and vital signs. We have to investigate and look for the cause of sinus tachycardia, because the only way to treat sinus tachycardia is to fix what is causing sinus tachycardia. So here's a long list of things that cause tachycardia, and you don't need to memorize it because you've already had all these things. And as I start talking about more of the conditions this semester, you're going to learn that sinus tachycardia is it's a compensatory mechanism, and it's one of the first signs we're going to see in a lot of the conditions we'll be talking about this semester. Okay, so usually to treat that, you just look for the causes. And then for first degree block, again, remember this is really a sinus rhythm. It goes from the SA node to the AV node down the bundle of His. So it could be a normal rate like 60 or 100, or it could be as the PR interval gets longer, they may have sinus brady. Not a big deal, okay? The PR interval is greater than 0.2 seconds. And when we're in class, I'm going to give you some practical solutions to figure that out, how to figure that out really quick. The PR interval, okay? Because you don't necessarily have to measure it. I'm going to show you how to do it quickly. You're going to check the LOC and vitals, and if your patient is fine, you're going to investigate. Okay, so beta blockers, calcium channel blockers, and digoxin can prolong the PR interval. So what that means is, if my patient gets placed on digoxin and they develop a first degree block and they're stable, I'm going to note it, but I'm not going to worry about it, right? I'm not going to call a physician in the middle of the night and tell them something that is a known condition that's going to happen, okay? So I don't worry about it. I just watch it, okay? ATI likes to test on high potassium or low potassium because first degree block can be caused by either high or low potassium. And how they'll word it, they'll say something like the P wave is far from the R wave, or the P wave is far from the QRS. Okay, so just keep that in mind. All right, so those are sinus rhythms. Does anybody have any questions about sinus rhythms? All right, we're going to go to atrial dysrhythmias. Now, when we talk about atrial dysrhythmias, remember that the P wave represents atrial depolarization. So when we talk about atrial dysrhythmias, the P wave is either going to be early, it's going to be missing or replaced with fib waves or sawtooth waves, or it's going to be buried in the T wave, okay? And I'll explain further. All right, so this is a PAC, a premature atrial contraction. So this P right here came early, okay? Or this P, look, this is atrial fibrillation, is missing. No, there's no P waves in atrial fibrillation, and it's replaced with fib waves. Here's atrial flutter. Again, the P wave is missing. It's replaced with these sawtooth waves. Now, students get atrial flutter and sinus tach confused. If you look here, there's 3 even bumps, okay? I'm going to go back to sinus tach for a minute. I come back here, look, these are uneven bumps. My students used to call these double butt cheeks between the 2 QRSs, okay? So that's how you're going to tell the difference between sinus tach and a flutter. Okay, so you'll have 3 or more flutter waves. And then they're also described as sawtooth waves. All right, or the P wave can be buried in the T, meaning it's not visible. So this is SVT. It's a very fast rhythm, greater than 150 beats per minute. It's so fast that the P gets hidden in the T wave. Okay, Okay, so this is a little chart we can kind of compare and contrast. So with the PAC, the rate will vary. It's usually normal sinus rhythm. It could be sinus tach, um, just because of what usually causes it. It could be sinus tach, but the rhythm is going to be irregular. However, most of the rhythm would be regular, but it will be irregular because that early P wave is going to cause one of those QRSs to be earlier. So the PR interval is going to be normal in the normally conducted beats. It'll be shorter in the premature atrial contraction. The QRSs in all atrial dysrhythmias is normal because although there is an atrial dysrhythmia going on, the impulse is always coming from above the ventricle. So it's supraventricular. Okay, so with atrial dysrhythmias, there's something wrong with the P wave, but the QRS is always going to be narrow. So what are you going to do first? Well, with all these dysrhythmias, we are going to check the LOC and the vitals. Just like what I told you before, the brain gets 25% of your cardiac output. So you got to make sure that the patient's brain is perfusion as well as, the blood pressure and the normal vital signs. The treatment for PAC is to stop eating dog snacks, eat healthy. And this is a mnemonic that tells you the main causes of most ectopic dysrhythmias, okay? So there's stress, alcohol, digoxin, stimulants, including illegal drugs, electrolyte imbalances, usually potassium, magnesium, and then hyperthyroidism and hypoxia. Okay, so the cure is like stop drinking your double mocha chaka, whatever, and you'll stop having PVC. So you have to withdraw the sources of stimulation with the PAC. And we don't like really worry about PACs that much, if the patient's pretty stable. Sometimes they may complain they're having palpitations, but they usually do fine. Now with SVT, this you definitely have to know this rhythm and how to recognize it, how to treat it. It's, yeah, highly tested. Okay, so this is a regular rhythm. Heart rate is going to be greater than 150. Remember, it's going to have a narrow QRS. You will not see a P wave. It'll be buried in a T wave because the rhythm's so fast. So you cannot measure a PR interval. You're going to check the LOC and vitals. Okay, if your patient is stable, I mean, they have a good blood pressure, they're talking to you, maybe they might complain of palpitation, but they're not complaining of chest pain. You're going to do vagal maneuvers first. So if they're stable, you vagal. Okay, so you're going to ask them to bear down, put cold water on their eyes, make them drink through a straw. I mean, there's a lot of things you can do. And now, if that doesn't work, they're going to get medication and they're going to get adenosine. That is giving in a vein near the heart. You push hard and fast, and they'll get 6 milligrams, and then it can be repeated with 12 milligrams. Okay, so that's the treatment. If the Valsalva maneuver doesn't work, you're going to give adenosine. Now, anytime you have a tachydysrhythmia, okay, it shortens diastole. Diastole is when the coronary arteries fill, okay? So if you shorten diastole when the coronary arteries are filling, your patient can have ischemia, okay? Coronary ischemia, or they can have actually an MI, all right? So if your patient's unstable with a tachydysrhythmia, so let's say they get short of breath, let's say they're difficult to arouse, let's say they get confused, they have chest pain, okay? It's time for electricity. The electrical therapy for tachydysrhythmias that are unstable is synchronized cardioversion, okay? So if they're unstable, meaning they have chest pain, they're drowsy, they're confused, they have shortness of breath, they complain, I said chest pain, that goes to, they're going to have synchronized cardioversion. It's for tachydysrhythmias that are unstable. Okay. Now with AFib, that's the P wave is totally missing and it's replaced with fib waves. Okay. Now, if it's a normal rate, 60 to 100, we call that controlled. And if it's fast, we call it RVR, rapid ventricular response. The rhythm is highly irregular. There are no P waves. I told you you can't measure the PR interval. You can't measure the QRS. You can measure the QRS, sorry, the QT. You're going to check the LOC and vital signs. The other thing too with these dysrhythmias, okay, the kidneys also get 25% of the cardiac output. So you may see a drop in urine output if somebody sustains a dysrhythmia for a long time. So with AFib, the goal is usually if they're symptomatic with a rate, you want to control the rate, control the rhythm, and prevent stroke. Okay, so usually you can control the rate and rhythm with diltiazem or amiodarone IV. That's the, you know, they usually give that for them. Preventing stroke, they're going to need to be anticoagulated. Okay, so we will be going into like heparin, warfarin. You're going to have to remember, you're going to have to know the testing that you do, right, for which drug, because it's different. The antidotes, what levels we're looking for, and we'll be delving into that, you know, for exam 1. But you're going to have to review all that stuff now. When the atria are not contracting, in AFib, they're just quivering, right? So that means the blood is pooling in the atria. And whenever the blood pools, you can develop clots, which is why they need to be anticoagulated, because they can have a stroke, an embolic stroke, and they can also have a PE. So those are two things that could happen to them. So we don't want that. Okay. So the reason, so it'll be controlled with medications first. Okay. And usually patients do okay with that. If they want to convert it, the treatment is synchronized cardioversion. However, if the patient comes in and the physician is unsure of how long they've been in AFib, they will do a transesophageal echocardiogram, because they're looking for a clot. Because if they cardiovert and the patient has a clot, they're going to stroke out or have a PE. Okay, so that's really important to know, and I'm going to go into more depth with that. Atrial flutter is, I kind of put them in the same bucket just to make it easier for you. They're the sawtooth waves, but this is a regular rhythm, okay? So if we kind of look at this overall, okay, PAC and AFib are irregular, SVT and A flutter are regular, okay? And it's the same treatment if it needs to be treated. All right, so SVT again, because this is highly tested. If they're stable, you're going to vagal. If they're unstable, they need the cable, so they need synchronized cardioversion. Remember, the P wave is buried in the T wave. There's only 1.5 to 2 big boxes in between. 2 big boxes would be 150 beats per minute. So that means they're in SVT. Usually SVT is caused by somebody's born or they develop an accessory pathways. There's all different names for it. You don't need to know any of that. I'm just pointing it out because when you give adenosine, okay, the purpose of that is to stop the conduction. So they go into asystole. It's kind of nerve wracking. So you need to warn your patient. They may have chest pain. They may vomit when they're getting their adenosine. Okay. Make sure you have suction ready. Make sure, you know, if they're going to vomit, you turn the patient on the side. Okay. So remember, tachydysrhythmias that are unstable are treated with cardioversion. Okay, now with AFib and A flutter, this is A flutter. This is AFib. Okay, with AFib, I talked about the atria are just quivering. That's why they can develop clots. So they also have a loss of the atrial kick, which is a key point, right? The atrial kick is what I was talking about. The atrial kick is when the atria contract, and that contributes 25% to the cardiac output. Okay, so that's why it's a key point. So there's kind of a triad of symptoms that your patient in AFib can have. They're going to have palpitations, or they'll say, I have like a racing heart. They'll feel that. They'll have shortness of breath. Anytime you have low perfusion, patients get short of breath. They're going to be extremely fatigued. And they could be dizzy and have lightheadedness. Okay. They have difficulty exercising. We had a lady that waited like a week to come in, and she couldn't even walk to the bathroom anymore. She didn't know what was going on, but she had AFib the whole time when she was home. Low urine output is another condition that can happen with AFib, any dysrhythmia actually. Now, you assess for a pulse deficit because AFib and PVCs are the two rhythms that can cause a pulse deficit, which HEI loves pulse deficits. Okay. We're going to watch out for symptoms of a stroke. They could be treated with amiodarone for AFib, esmolol, diltiazem, digoxin is also for AFib. Okay, anticoagulation. Remember with warfarin, we monitor the INR, and we want the INR between 2 and 3. The higher the INR, the greater the chance of bleeding. So make sure you have vitamin K available, okay, because that's the antidote. And teach patients not to increase eating green leafy foods, okay? And look at this other name for vitamin K. You're going to need to know that. There are novel oral anticoagulants, and the benefit of them is you just don't have to test, and they can eat whatever they want. This was the transesophageal echocardiogram I was talking about before. So your patient would have to have this done if they had AFib, okay? And I see them do it on everybody, even patients in new AFib, but it's to make sure they don't have a clot. Okay, so monitor for vagal reaction during, because they're putting this down their throat. Make sure your suction is working well. Before you do any procedure that involves conscious sedation, make sure your suction is working, not just that it's put together, like actually turn it on and put your finger on the end of it to make sure it's sucking, okay? And then with cardioversion, okay, I don't know if you've seen a cardiac monitor. Ask your instructors when you're in clinical to show you the cardiac monitor. It needs to be on sync. It's called synchronized cardioversion. The reason is it prevents you from delivering electricity on the Q wave, because if you deliver it on the Q wave, it's called R on T syndrome, and the patient can go into VFib or VTAC. If you're doing synchronized cardioversion and your patient goes into VTAC or VFib, you need to turn the sync off and defibrillate right away. That's a key point. So if you're assisting with cardioversion, synchronized cardioversion, your patient goes into VTAC without a pulse or VFib, you need to turn off the synchronization, and then they need to be defibrillated. That's a key point. Okay. And then the treatment for recurrent AFib, SVT is radio frequency catheter ablation. Okay, and if you need the answers, they're in your OneNote. Here are all the herbs you need to avoid. Okay, and I know you've been tested on that in previous proctors. All right, these are the causes of atrial fibrillation. Do not memorize them. I'm going to give you just give you some advice. You're coming into practice where you're going to be taking care of a lot of older adults, and like literally any kind of illness can put them into atrial fibrillation. So it's very common. Just think stimulants, think stress, infection. I just really wouldn't worry about the causes. I would worry more about the presentation and the treatment. Like, how is my patient going to present with atrial fibrillation? Okay. Does anybody have any questions about atrial dysrhythmias? Okay. Now, I'm going to go in and teach you about complete heart block. It's called third degree heart block, or some you might hear it called AV block, atrial ventricular block, because there's a block between the atria and the the ventricles. Okay. So you don't need to know if it's high block, low block. It doesn't matter. I'm going to give you some clues so you'll know right away if somebody's having a block. Okay. If there are more P waves than there are QRSs, that means there's a block. What actually happens in third degree block is that the AV node is not conducting, and the impulse from the atria to the ventricles can only go through the AV node. That's the only way it can communicate. Okay. So if something's wrong with the AV node, they're going to get a block. So the P wave, the normal rhythm of the SA node, or rate, I should say, is 60 to 100 beats per minute. So your P wave is going to map out to like 60 to 100 beats per minute. But the QRS is coming from the complex, is coming from the ventricles. So it's going to be slow. So as you can see here, there's only 3 QRSs to 1, 2, 3, 4, 5, 6, 7 P waves. So that's how you can tell. Third degree is the only rhythm where the P wave can be buried in the QRS. If you see right here, it's buried in the QRS. Doesn't happen in other rhythms. So both the atrial and the ventricular rhythm are regular, they're just not communicating. Okay, so you don't have to really, that's all you have to know. You don't really need to know the causes either, because usually you're given a situation like MI is the one that's I see most common in tests. And the reason you're tested on it, quite frankly, is because it's very dangerous. Okay, so with third degree block, it doesn't respond to medications because there's something wrong with the AV node. Okay, so even if you gave like atropine, the SA node would probably go crazy and you'd have like, increase in your P waves. But the only thing that's going to work is a pacemaker, and the patient's probably going to need a permanent pacemaker. What you're going to do, of course, is you're going to assess. So if your patient has a really weak pulse and they're unresponsive, it's time for you to start CPR. Okay, it's going to be a code. Now, if they're stable, okay, you need to get the temporary pacemaker until a permanent can be placed. So you're going to put the cutaneous pacemaker on the patient's skin, and you're going to call a rapid too if they're unstable. Okay, so here's how you would do it. You see one on the front, one pad on the front, one pad on the back. And when you're in clinical, ask your, I used to take my students to the monitor and I would show them everything on the monitor so they know what I'm talking about when I say, the pads and the sync mode. So you can ask them to do that. Now, it can be, these are burns, electrical burns. So you can burn your patient. So be looking for these. That's quite painful. The pacemaker is quite painful. So hopefully you'll just need to put it on as a precaution and not really use it. Okay, so that's third degree. Okay, now with ventricular rhythms, we're going to talk about PVCs first. Now, PVC is an early, wide, bizarre looking beat, okay? And it's wide because that beat is coming from the ventricle. So somewhere in the ventricle, that area is irritated, okay? Usually it could be like from the dog snacks, low potassium, low magnesium. That happens a lot. When I worked in PACU, when my patients were waking up, they'd have frequent PVCs. Now, if you look at this first one here, these two PVCs are what we call unifocal. So they look the same, okay? See how they're both, the deflection is both going down? Okay, so this is unifocal. Okay, this is unifocal. See how they both look the same? These two, unifocal. Okay, now this is multifocal. This one's going up, this one's going down. Okay, now I'm a little bit more worried about multifocal than I am about unifocal, because multifocal means there's like two areas of the ventricle that are stressed, okay? Whereas unifocal means just one little area is stressed, okay? With PVCs, this is high yield. You need to know you're not going to worry about PVCs until they're greater than 6 a minute. That is a key fact. It's greater than 6 per minute, you need to worry about your PVCs. If they're not in reality and practice, you really don't worry about them that much. Some people just live with PVCs. But for the repetitive PVC rhythms, bigeminy means there's a PVC every other beat, and trigeminy means there's a PVC every third beat. A couplet means two PVCs together, so I'm more worried about a couplet than I am about trigeminy or bigeminy, because 3 in a row, 3 PVCs in a row is a run of VTAC. Okay, so the couplet worries me more than trigeminy or bigeminy, because I just need one more beat and it's a front of VTAC. All right, so your typical dog snacks are going to cause this kind of ectopy. So assess for a pulse deficit, more than 6 per minute. I told you that's high yield, so you don't worry about it. If the patient does have signs and symptoms of low perfusion, you find and treat the cause. All right, and this is unifocal, and that's multifocal. Okay, and students get AFib and VFib. This is AFib. We have narrow QRSs because it's an atrial dysrhythmia. It's irregular. This is VFib. Okay, it's just like a wiggly worm, like a wet noodle. Okay, and then VTAC is 3 or more PVCs. Now, how you can distinguish VTAC from VFib, if you look at VTAC, it's regular rhythm, right? And I can clearly count 1, 2, 3, 4. I can count. Here, I can't really count because I don't know, like, am I counting this little thing right here? Am I counting this little thing? Okay, so this is not regular, okay? So with VFib and VTAC without a pulse, these patients are dead. Okay, VTAC and VFib without a pulse, they're dead. They get defibrillation. These are the only two rhythms that get defibrillation. With VTAC, remember you have to check the LOC and vital signs before you defibrillate somebody, because they could just be sleeping. But with VFib, you're gonna defibrillate. That's your main goal. Okay, so with the lethal dysrhythmias, again, VTAC, 3 or more PVCs in a row, regular, they're countable, they have wide QRS. First thing you're going to do, this is VTAC, you're going to check the LOC and the pulse. If they're stable, you call the provider right away. They're going to order some amiodarone or adenosine IV, okay? If they're unstable, it's a tachydysrhythmia, so they're unstable. They still have a pulse, okay? They're going to get synchronized cardioversion. Cardioversion is for people with tachydysrhythmias that have circulation, okay? So they're going to get synchronized cardioversion. And this is when you synchronize, you'll see these little arrows above the QRS. Sometimes they have X's above the QRS. And that's just telling you that this is on sync mode, okay? Because you do not want to deliver electricity over the R wave, because they could go into VFib or VTAC without a pulse. So if they do go into VFib, you're going to turn the sync off and you're going to defibrillate if they're in VFib. All right, with cardioversion, it is a procedure, so you're going to get a consent. You're going to do conscious sedation with midazolam and usually some fentanyl. Flumazenil, that is the rescue med. You want your QRS is upright, lead 2. I forgot to mention that. So lead 2, all these rhythms I'm teaching you rhythms in lead 2. All right. No O2 while you're defibrillating. So anytime you have electricity and oxygen, don't mix. Okay. No digoxin for 48 hours. People cannot be defibrillated. I think that was a practice question on the ATI assessment, practice A. No digoxin for 48 hours beforehand. You're going to call all clear. Anytime you deliver electricity, electrical shock, you say, I'm clear, you're clear, we're all clear. So we want to make sure everybody is clear. Again, here's your VFib. If you are doing cardioversion, synchronized cardioversion, and it turns to VFib, turn off and synchronize and defib. This is Torsades de Pointe, and it is a variation of VTAC. See, it gets big, it's like turning on itself, big and small. The treatment for that is magnesium, and it's the only time we give magnesium in cardiac arrest. Okay, shockable rhythms. Remember, it's VFib, VTAC without a pulse. They're dead, so they get defibrillation, okay? Because people with circulation get cardioversion, okay? All right, it's a priority. You want to get within 2 minutes of, the patient going into this rhythm, okay? You can't stop and sedate. Your priority is to defibrillate, all right? It's asynchronous, meaning it's not on sync mode. You don't need to know the difference in the joules, but the joules you're going to give are 200, okay? You don't need to, you just need to know you need to assess for causes, but you don't really need to know these causes, okay? The nursing implications for defibrillation, you want to make sure that you're doing CPR in between shocks, and it's high quality CPR. You remove the oxygen anytime you deliver a shock. You make sure it's clear so all others away. You charge the defibrillator. While you're charging, you make sure you're doing high quality CPR. You want hands off everybody. That's when you're given the electricity. And then evaluate the rhythm after you shock them, okay? And then defibrillate if you must, if the patient is in cardiac arrest. Okay, so the treatment for cardiac arrest, the priority is defibrillation, high quality CPR, and epinephrine. Epinephrine is a drug that all dead patients get. So all dead patients get epinephrine. Okay, I know that's kind of crass, but it just helps you remember the D for dead in defibrillation. Okay, now there are some unshockable lethal rhythms. There's like asystole. Now, before you give CPR to somebody with asystole, make sure the lead just hasn't popped off, okay? So you're gonna assess the patient first, and if they are unresponsive and pulseless and not breathing, then you're gonna do CPR and epinephrine and find the cause. You just have to assess for the cause, okay? With pulseless electrical activity. This means they have a beautiful rhythm, but no pulse, okay? So the heart is not responding. So the treatment for this is, it's called PEA. So you're gonna push hard and fast. So that means give high quality CPR. You're gonna give epinephrine, okay? That's the treatment. And you are going to assess for the cause. Those are, for PEA, you're going to do 3 things and 3 things only initially. Okay. And if someone is unresponsive without a pulse, you don't need to do any more assessment. That's enough, right? It's time to act. Okay. All right. So find the cause. You don't really need to know like the causes. You need to know that you need to find the cause. Okay. Pacemakers. Now remember, pacemakers are the electrical treatment for Brady dysrhythmias that are unresponsive to medication. So sinus Brady, if it was on, you're always going to give like your atropine first if they're symptomatic. Okay. They usually respond to that. Pacemakers are usually for people with third degree block. Um, Also, like people with end stage CHF, where it affects both sides of the heart, they may get a biventricular pacemaker. Um, so, what you do need, what has shown up on the proctor before, I'm just going to keep this super simple. If you, when the pacemaker is set, the settings on the pacemaker, it delivers electricity, there's a spike, okay? So this spike is coming before the P waves. So this patient is atrial paced. The atria are paced in this rhythm. This rhythm right here, you've got a spike and then a QRS. So this is a ventricular paced pacemaker. However, this is concerning. Right here, you have a spike and no response. That's called failure to capture, okay? And then patients can have a atrial ventricular pace or an AV sequential or dual, and that means both chambers, so the atria and the ventricles. And anytime you have a paced QRS, it's going to be wide, okay, wider than usual. All right, you don't really need to know the three-letter system, asynchronous or synchronous. Just know this failure to capture. You have a spike and then no response. That's called failure to capture, and that is could be a medical emergency. So that's your patient. Okay, implantable cardioverter defibrillators. They can be combined with a pacemaker or they can be done alone. It's for people that have survived cardiac arrest. Okay. Any of these procedures, after they're done, you always do a chest x-ray, like even when somebody gets like a central line, to make sure they don't have a pneumothorax, okay? Notify the provider if the patient has hiccups, because then they're going to need to go move the wire, okay? It's tickling their nerves. All right, so your patient teaching, anybody with a pacemaker or ICD needs to wear a Medi-Alert badge. They need to learn how to take their pulse for 1 minute every day. They can be near a microwave, however, they have to use their cell phone on the side opposite the pacemaker. So how I've seen that question worded is 6 feet from the chest is what the phone needs to be, or on the opposite side. They may need a sling for a number of weeks. They cannot raise their arm over their head on the side it was put on. They may have trouble going through when they're shopping. So if they kind of feel something, they can just back up and back away. On day 4, they can bathe, they can have sex. They cannot ever have an MRI, use a TENS unit. They can travel, it's safe to travel. However, they cannot go through the airport security. Okay, so they'll have to let the airport security know that. And, they can't go through any of those machines there. Look for infection. They should not wear anything that is going to put pressure on the pacemaker. They need to carry their medication list with them. If their ICD fires 1 time, they call their provider. If it fires twice in 1 day, sorry, this is in 1 day, they're going to call 911. Everybody in the household needs to know how to do CPR, and they may be able to swim 4 weeks post-op. Now, and driving too is another thing they have to get permission to do right after. No contact sports, no heavy lifting. Okay, now they could develop pericarditis. So remember the symptoms of pericarditis so you can identify it. So with pericarditis, they're going to have pleuritic chest pain, which means they have pain when they're breathing. Usually it's breathing in, but if you lean the patient forward, the patient's going to get more comfortable. Okay, so sitting up and leaning forward makes the pain better. Okay, they're going to have a fever, they're going to have a high white count, they'll have a pleural friction rub, not pericardial friction rub, sorry, pericardial friction rub. So it'll sound like crunching or grating. They may have trouble swallowing. So that's pericarditis. And why we worry, okay, is if it fills with fluid, the fluid may stop the heart. It may tamponade the heart. So you're going to have to know the signs and symptoms of cardiac tamponade. So hypotension, JVD, and muffled heart sounds are like 3 hallmark signs, okay? Also, you'll see something called electrical alternatives, a small QRS and a big QRS, okay? Not a big deal. I already talked about the main signs you're going to see. Now, it's tachycardia with tamponade because our body is amazing and our heart tries to help us because it knows that the heart can't pump efficiently, so that it tries to speed up the heart rate. Hypotension, narrow pulse pressure, and a pulsus paradoxus, which means that the BP is going to increase on inspiration. Okay, so and how it'll be worded like on exams and stuff, it'll say the patient has a paradoxal pulse. If somebody has a paradoxal pulse, right away I'm thinking cardiac tamponade. Okay, that's exactly what I think. So you have to be able to recognize that. All right, electrolyte effects on the ECG. Okay, I told you about low K and trigeminy. Okay, also they can develop a first degree block. They can develop a U wave, which hardly ever see. With high potassium, you can remember the mnemonic WASP. They could develop a wide QRS. They could have ST elevation and peak T waves, and they can also get first degree block. You don't need to know what the signs for each one of these things is. Just know what I told you about what you might see with a high potassium and a low potassium. You don't have to like know the levels. All right, and calcium we're going to cover in more detail when we get to the second exam, when we talk about pancreatitis, okay? But one thing, hypercalcemia, think low QT, and hypocalcemia, think long QT. Anytime the QT gets longer, they're at risk for torsades, okay? Torsades day point. All right, but potassium is really important. All right, are you guys dead? How are you doing out there?
Good.
Here.
I'm here.
Any questions?
Yeah, just trying to keep up with all of this. It's a lot.
Right, right. So what are you having trouble with? Like, what's your approach?
I'm just note taking and going to go back over it again and again and again, like until I've like beat it in my head. That's gonna be my approach.
Okay. Anybody else have a different approach?
Color ink pens, just to kind of make it easier to have it to stand out.
So what do you write your questions in red or your?
I write my notes in like hot pink or red, and like my note cards, like at the top, I put like hyperkalemia on the EKG and like draw a little diagram or whatever, and then just write notes like, tall
Right,
P wave or whatever. Yeah.
right. But we're keeping it real simple, right? So like if you work in a cardiologist's office, don't start talking to them because I'm not teaching you how to read an ECG. Okay, I'm teaching you how to read a rhythm strip. Reading an EKG is a totally different skill set. This is just one view. Okay, so we only have to really deal with one view of the rhythm strip. Do you have any questions? So in class, we have activities that are going to like strengthen this knowledge, right? And so after class, within 24 hours, you need to start looking through all those activities and because you're going to see, oh, she talked about this such and such, and I remember hearing about this. the important things are going to be pulled out in your class and what we learned in the class. So make sure you're reflecting on like your classroom time and also like the activities we do. Go back and read your case studies again and add some notes and compare them with your notes, so to speak. Students usually hate the escape rooms. They're like, they're so hard. And I'm like, yes, but your exams are hard too. So you really need to take the time, if we have that as a classroom activity and, look up the information and, try to figure out what the questions are asking you, because that's the thing students have trouble with the most. Does anybody have any other questions? Okay, so make sure, like, remember, the worksheets are your Bible, okay? So make sure not only do you read them again, right? And read them over and over, but you understand them. You understand, like, if this happens, what am I going to do? What kind of assessment am I going to see in this patient? What do I do first, right? I gave you some good tips in this tutoring about, what you're supposed to do first and why somebody with a dysrhythmia can have a change in their LOC. And, that needs to be treated right away. Okay, so that patient is unstable. Nobody has any questions?
Could you repeat? You said something about death, and you said defib. I guess could you repeat that
Okay,
again?
so listen, tachydysrhythmias with a pulse get synchronized cardioversion because they have circulation. So people with circulation get cardioverted.
Okay.
V-tach without a pulse and V-fib, that patient's dead. Dead people get defibrillation.
Okay, Miss Cohen, you know what? I think I just so VFib is where is VFib coming out of a different area of the heart versus AFib? Because
Yes.
okay, that's
So
where
yes.
I literally
Okay, where did I have
gotten
that picture?
confused.
Okay, let me go here. Hang on. I think it's down here. Okay, so remember when we were going over atrial dysrhythmias, I said with atrial dysrhythmias, there's something wrong with the P wave, right? It's either early, it's missing and replaced. So with AFib, it's missing and replaced with fib waves, and you're going to have QRSs. See these narrow QRSs? They're irregular, but they're narrow QRSs. Okay, so with VFib, okay, it's just a mess here. There's nothing going on here. The whole heart is quivering. Here, only the atria are quivering.
Okay, because when you said when VFib is one of the shockable rhythms, I
Yes, the
think that
patient
I
is.
just misunderstood. I just got a little confused that why are we shocking AFib? Okay,
No,
I think I'm understanding it a little bit more.
VFib and pulseless VTach. Remember,
Right.
you're not going to defibrillate somebody in VTach unless you check that pulse. So you're going to check the pulse and LOC first, right? And if
Oh,
it's pulseless, then that they get defibrillated. These are the only two rhythms that get defibrillated.
okay. All right.
Yeah,
So
good
essentially,
question.
the ventricle part of the heart is where it becomes deadly, because you can't.
Well, okay, so if you think about it, the biggest part of your cardiac output is going to come from that ventricular contraction.
Gotcha.
So if your ventricles are just quivering, they're not going to be able to contract hard and give you like a cardiac output. because the ventricles are just quivering in VFib. They're not contracted.
It makes sense. Yeah.
Yeah.
Thank you.
And so in
Okay.
AFib too, the atria are not contracting, they're just quivering. That's why we have to worry about, them getting thrombus in their atria. Okay, because they're not pushing the blood around. The blood is just stagnant because the atria aren't contracting. Good questions. Any other questions?
My question earlier before we got started about the hypo and the hyperkalemia, I
Mm-hmm.
understand it now when you went through it briefly about how it looks on a reading, not a reading, but on that
The
particular rhythm.
ECG.
Yes,
Yeah,
yeah, I understand it now. That was my
yeah.
question, but I got
And
it.
so also, Dominique, you just reminded me, students usually get upset when I say this, but this is a complex med surg class. So these
Hmm.
dysrhythmias are going to follow us the whole semester because all the conditions we talk about, the patient's going to be at risk for dysrhythmias, some type
Gotcha.
of dysrhythmia.
Is that because of like electrolyte imbalances?
Yes, a lot of the things, electrolyte imbalances, or like when I was talking about pancreatitis with the low calcium, and then we have renal disease, so yeah, all the conditions we talk about could result in dysrhythmias.
Thank you.
You're welcome. Does anybody else have any questions? Okay, so this week in my classes, I'm mentoring somebody that's doing their master's degree. So she'll be observing. And then hopefully, I think next week, I'm hiring somebody to teach this class. And I think next week, they may be good to go at that time. And I'm going to mentor them. Don't worry. They're going to get a good experience. And you'll still get a good experience. Um, I'm committed to make sure that you're all graduating on time. Um, any questions for me?
How much of the ATI book will help with our studies?
Okay, ATI is Cliff Notes. Your textbook is deep. However, you don't have to read every word in your textbook either, right? But if you don't understand like the physiology behind the dysrhythmias, or you're struggling, you may have to read your textbook for the rationales.
Okay.
Yeah. So you should be doing a lot of assessments though. Right? Like you got, okay, so if you're in 270 this semester, you probably don't know this, but if you go to your ATI, there's a section called NCLEX Prep. And it may not be there now, but it will be soon. It's called Board Vitals. You need to get in there and do the critical care questions, and
It
it's
opened up
kind of like,
Friday.
you have it.
I do.
You already? Okay, so it probably dropped already. Yeah. So start doing those questions in there, the critical care ones, especially, and the cardiovascular ones. They're really good. They're a little bit more detailed, I guess, than the ATI Learning Systems 3.0. So that's more like what your exams will be.
Okay, thank you.
You're welcome. And if you're like, Wanda, when you were asking me about the reading, if you're, I love ATI. I'm a big ATI fan. I wish I had it when I was in nursing school. But if you're like struggling to understand something, that, that's what you really need your textbook for. And your textbook does a good job of like putting things in tables, bringing things out like, in boxes and things. Because if when I write an exam, right, I don't go and like read every little thing in the textbook. I'm looking for bolded words, italicized words. I'm looking for things that are in a table. If it says important fact or patient-centered care, I'm looking at things like that to write exam questions about.
Okay.
So don't feel like you have to get buckled down, right? You just have to know how to like cherry pick and read your key points at the end of the chapter first, you know. But usually, like if you listen to me long enough, I'm like, you got to know this key point to bring out what's most important. Has anybody done the hemodynamic monitoring?
I've had some
I
experience with it.
have.
You have, okay.
Mhm.
It's confusing, right? Because you've never seen it. Have you seen it before?
Yeah, looking at it like in person, it makes more sense because you have to make sure that it's level so that you can get the right readings that you need to be like for that particular patient. It's
Yeah.
pretty neat.
Did you get
Yeah,
to do that in clinical last semester?
I did.
Okay, good.
Yeah, I was able to pull off of the A line, make sure that the patient was level. It was pretty interesting. It looks more intimidating on paper, but when you actually see it, it makes more sense.
Uh-huh. I'm gonna review it the first class, but probably bring the set up the second class
Yeah, it will be
so we can
helpful.
kind
I
of go
think.
over it twice.
Yeah, I couldn't understand it at first, but then like when you actually see it, it makes more sense. And you
Uh-huh.
actually see the numbers level. If the patient like if it's lower, the piece that actually goes on the IV pole, actually I'm looking at it now. So it's like the valve. If it's lower on the IV pole and your patient is not level A line, meaning right there at the heart, then the numbers are going to like be off. So you have to
Right.
make sure that they're all like, I mean,
But let me
decently.
ask you this, Dominique. What is the
Mhm.
most important thing the nurse has to do when a patient has hemodynamic monitoring?
Um, I mean,
Especially like an A line.
you want to make sure that infection control. That was the biggest thing that the nurse made sure. Like everything had to be in like stir whenever you got like blood, and the it's the valve. Got to make sure that that valve is like closed off and not open. That's the biggest thing that she kept saying, but I could be
Okay,
wrong.
but before you leave that room, what is the most important thing you have to do?
I have to refresh my memory. I fell on the spot. Sorry.
Okay, so somebody has got an arterial line in their
Repeat
artery, and
pulses.
you all know that arterial bleeding is fast bleeding, right? The
Mhm.
arteries are stronger, they have muscle in them, and you don't it's kind of like an IV but in the artery, okay? And most of them aren't sutured in. So they could pull that out pretty easily. The most important thing you
It's
need
check
to
the
remember
side.
is to make sure your alarms are on your monitors because they
Mhm.
could bleed out if you don't have your monitors on.
Yep, you did
So
check
that
that too.
is really important. When I first started working in critical care, I'd walk out of a room and the nurses would be like, "Get your monitors on." They were like the monitor police beginning it, but it was like the culture there, like you couldn't walk out of your room. And then you'll learn when you go to clinical, there's a way you can pause them while you're working in there. But you're right, it is important to prevent infection.
Mhm.
But they can bleed out pretty quickly, so you got to watch for that too.
And if anyone get a chance to pull, like, get lab work off of an A line, it's the most thrilling thing because you actually feel the pressure and it comes in so fast. Like it's pretty neat. It's pretty cool.
I used to love it when my patient had A lines because it makes like the labs so much easier. You get ABGs, you can it
Get your
does make it
glucose.
easier.
You can get a lot from that A line. It's pretty neat.
It is.
Just that was pretty interesting. I think that was the most interesting thing. Yeah.
Yeah. Okay, well, we'll talk more about hemodynamic monitoring. I'll keep it super simple, give you the key points, and then we'll see a setup in the lab the following week. And I'm going to bring my carpenter level, and we're going to make sure it's referenced to the right point. Okay? All right, y'all. If you don't have anything else, I'm going to see you Wednesday or Friday. Okay?
All right. You have a good
Dr.
evening. Thank
Cohen,
you.
Yes.
quick question. Are the worksheets due on Wednesday? I didn't see it turn in place.
Is the classroom opened?
Yes, the classroom opened last night about like
It
11
did?
o'clock. Yeah, the
Oh.
classroom opened, but I think according to the tracking shell, it is due next Wednesday. Well, I'm Wednesday, so next Wednesday, not this week, but unless she
Well,
changes.
they're always due before class. And what do I have it on the tracking calendar?
You have it on the tracking calendar, June 13th.
Oh, dang. Okay, June 13th.
Thank
But
you.
you're gonna want to get them done. I'll tell you why, because you have them done. You have to do them before each class. Like don't like you have to stay. Like let me give you a piece of advice. You have to stay ahead in this class. You have to study as we go. You cannot wait. Like 2:30. Don't tell Mr. Weichel I said this, but 2:30 is like fundamentals little bit teeny bit harder than fundamentals, but it's really going over fundamental principles. I mean, they're important principles, but you've already had a lot of that information. You've already had a lot of this information I'm giving you, but I think that the gap in between third and fifth semester, students feel like, oh my God, Mid-Surg 1 was a piece of cake compared to this. Well, this is the complex Mid-Surg class, so it is a little bit harder. So you really need to study as you go along. Don't wait till the week before. The students that do the best come to tutoring. They ask questions. They pay attention. They're engaged in class, and they do what I say about like looking at the material the next day and using those worksheets as a Bible and keeping up with them.
I'm not sure if anybody have gotten the chance to look at the ATI, the 2023 ATI books that they have available, but I found it very helpful. I'm not one that like to read a lot of verbiage. I'd be honest, but the ATI may be helpful if you have like some hard areas. I mean, I thought it was helpful just going through the medication part. So
Which
I
Does
can.
it have?
which
You said it was
edition is that?
interactive.
But say that again.
What edition is that?
It's in
It
the
is
electronic
edition.
one.
Yeah, it's an electronic edition 11. So when you first log into ATI on your first tab, it's gonna, well, for me, it's in the lower left-hand corner, and it's not gonna say ATI books. It's gonna be like RN like 2023, and it's
Oh,
going
really?
to.
Okay.
Yeah, and if you can't find that, you can go into your ATI book tab, and it will have all of the versions, like, well, not like 9 and 10, but it'll have the new version, and it will say 2023. It's a lot easier on the read, I know, for me,
Oh, thank
because
goodness.
the previous ATI books online, it mirrored the paper copy. So it was kind of like, well, I can just read a book if it's going to be the same, but it's more interactive. Like you have questions throughout the lessons, and I mean, it's interactive. I like it.
Oh, that's
I
good
think
to
it's
know.
pretty. I think it's pretty neat to that they've updated it, and it's an easier read too. I found that I've retained more with the updated version.
All right, that's good to know.
Yeah.
All right, so I didn't know the classrooms were open. I'm going to go check it out.
So I have a quick question. So if I'm looking at the tracking calendar now, yeah, the notifications last night, like 10, 11 o'clock, was like crazy for their classrooms.
Yeah, they do.
It says for week 1 to upload the practice A for MedSurge with the focus review. So are we following that, or are we following what's in Blackboard? Because Blackboard has that due next week and nothing.
Oh, I always put it as first on my tracking calendar, but I give you an extra week.
Okay. All right.
Yeah.
Perfect. Thank you.
Yeah, so make sure you're doing the focus review properly because I'm looking for your time spent in the focus review.
Okay. So we do the focus review like you showed in the video, and then a handwritten
Yes.
thing on the one we miss. Yep.
Yes.
Okay. Perfect. Thank you.
All right. You're welcome.
I have another quick question for the academic policies. Do that have
Yes.
to be 100?
No.
Okay, good. All right, that's all I got. I got a 90.
Yeah, there are some changes this semester.
Yes, the proctor, you all are
Right.
giving points, but you have to do the focus review. That's so much appreciated. I'm glad that was a big change.
Yeah. I've been complaining for a long time,
Yes.
but we got it. But I still want everybody to get a level 3.
Okay.
And a lot of people do get level 3s on this proctor.
Yeah, it's doable.
It's doable, definitely. Definitely. All right, y'all. If you don't have any more questions, I'll see you Wednesday and Friday.
All right, sounds good. Have a good evening, everybody.
Thank you.
You're welcome.